Hello, hello, hello. Good evening, coders. How is everyone doing? Let's see who is here tonight. Happy Monday. No, I'm not in here very often, but covering for Miss Melissa, and I'm so happy to be in here tonight. And I don't know why it says, actually, give me a second because this is not the right screen. Sorry about that. All right, I see some of you saying hello. Hello, Kim. How are you? Hi, Brittany. How you doing? So glad to see you in here. Okay, here we go. That's the right screen. Hello, Haji. Hi, Miss Patricia. I'm well. How are you doing? Katwana, hi. Happy Monday. Hi, Brenda. How are you? Okay, here we go. We're on track 1 this week, and we are covering Integ tonight. Wednesday, Miss Rochelle will be in here joining you all, and she will be covering the musculoskeletal and respiratory, okay? But tonight, it's all about the skin. So y'all ready? Hi, Craig. How are you? Okay. So let's go ahead and before we get started, I want to introduce you all to the wonderful team members that I have with me tonight. First of all, I'm Miss Tracy, for those of you who don't know. And joining me tonight, we have Mr. James. Hi, Mr. James. How you doing?
Hi, Miss Tracy. Hi, coders. Welcome to class and happy Monday. And let's have fun tonight.
Yes, let's do it. Okay, and we have Miss Jeannie joining us as well. Hi, Miss Jeannie. How are you?
Hi, Miss Tracy. Hi, Mr. James. Hi, Miss Angela. Hey, coders. It's a Monday fun day, so that is exactly what we're going to do. Can't wait to solve some scenarios with you guys.
I like that. Monday Fun Day. Thank you, Miss Jeannie. And last but not least, we have our wonderful Miss Angela with us. Hi, Miss Angela. How are you?
Hi, Miss Tracy. Hi, coders. Hope you guys are all having a good Monday and hope everybody had a great weekend.
I hope so. All right. Okay, we're going to go ahead. Thank you, Miss Angela. We're going to go ahead and get started. I'm just going to take a peek in the chat one more time and see if anyone new has joined us. If you're just coming in, say hello, hello. We'd like to see who's here tonight. Okay. So let's start off by reading the copyright. CPT is copyright of American Medical Association. All rights are reserved. CPC is a registered trademark of AAPC. And keyword concept, FTR, TON, AMCI, Fab 7, and Flip and Tap are all trademarks of AMCI. And our group study. Okay, as I suspected, we didn't need too much time on this one. I see a lot of answers that have come in so far. And it looks like, for the most part, we're in agreement on this one. Okay, so let's go ahead and reveal the answer. All right, so my keyword here is hyperplastic scar tissue, and that would be describing a keloid. So our answer is going to be A, okay? So a mass of hyperplastic scar tissue is also known as a keloid scar, and or also referred to as hypertrophic. And that's what it looks like. It's kind of just raised up, okay? That would be considered a keloid scar. Okay. All righty. So moving right along, we have our, actually this is an ICD-10-CM scenario pertaining to the Integ section. And I'm going to ask Miss Angela if you'd like to read this one.
Yes. Okay, so we have our answers A, C 44.319, D 04.39, D 48.5, and D 22.39. B, C 44.319, D 22.39, C 44.202, C 44.40, D 22.23, D 22.39, D C 44.202, C 44.309, D 48.5, and D 49.2. Okay, so operative report, pre-operative diagnosis, basal cell carcinoma, forehead. Basal cell carcinoma, right cheek. Suspicious lesion, left nose. Suspicious lesion, left forehead. Post-operative diagnosis, basal cell carcinoma, forehead with clear margins. Basal cell carcinoma, right cheek with clear margins. Compound nevus, left nose with clear margins. Epidermal nevus, left forehead with clear margins. Indications for surgery. The patient is a 47-year-old white man with a biopsy-proven basal cell carcinoma of his forehead and a biopsy-proven basal cell carcinoma of his right cheek. We were not quite sure of the patient's location of the basal cell carcinoma of the forehead, whether it was a midline lesion or lesion to the left. We felt stronger about the midline lesion, so we marked the area for elliptical excision and relaxed skin tension lines of his forehead with gross normal margins of 1 to 2 millimeters, and I marked the lesions of the left forehead for biopsy. He also had a lesion of his left alar crease we marked for biopsy and a large basal cell carcinoma of his right cheek, which was more obvious. This was marked for elliptical excision with gross normal margin of 2 to 3 millimeters in the relaxed skin tension lines of his face. I also drew a possible rhomboid flap that we would use if the wound became larger. He observed all these margins in the mirror so he could understand the surgery and agreed on the locations, and we proceeded. Description of procedure. All 4 areas were infiltrated with local anesthetic. The face was prepped and draped in sterile fashion. I excised the lesion of the forehead measuring 6 millimeters and right cheek measuring 1.3 centimeters as I had drawn them and sent in for frozen section. Biopsies were taken of the left forehead and left nose using a 2 millimeter punch, and these wounds were closed with 6-0 proline. Meticulous homeostasis was achieved of those wounds using Bovie cautery. I closed the cheek wound first. Defects were created at each end of the wound to facilitate primary closure, and because of this, I considered a complex repair, and the wound was closed in layers using 4-0 monocryl, 5-0 monocryl, and 6-0 proline, with total measurement of 2.1 centimeters. The forehead wound was closed in layers using 5-0 monocryl and 6-0 proline, with total measurement of 1.0 centimeters. Loop magnification was used and the patient tolerated the procedure well. Okay, so for this one, I'm going to give you, what do you think, Ms. Tracy? 2.5 minutes or 3 minutes?
We could do 3 minutes on this one, please, Miss Angela.
Okay, no problem. And your time starts now. Good luck, coders. All right, coders, and that's time.
All right, thank you so much, Miss Angela. All right, see some answers coming in still, so go ahead and get those answers in and we will tackle this one head on and see what's going on here. All right. All right, so it looks like I have a mix here of different answers. That's okay. I know it's a lot to sort through. This is a big scenario. And if I look at my answers, I see that A, B, C, and D. Well, actually, if I look at all these answers, well, A, B, and C, and D, the first listed code is one of those C codes. We also have some D codes as well. So with ICD-10, I like to look at the category letter. So we're dealing with C and D. C would be for, remember C for cancer, so those are malignancies, and D are usually those benign codes, okay, or non-cancerous. All right, so that's just some things to think about. Now, let's go look at the keywords, okay? Well, the first thing I do want to point out, remember when we have preoperative diagnoses and post-operative diagnoses, which one are we coding from? Which one do we code from when we have both of them listed? Post, okay. I see most of you are saying from the post. So in the setting of a pre-op and post-op diagnosis, we code from the post-operative diagnoses, okay? Those are more definitive diagnoses there. So we don't even look at what is going on. In our pre-operative diagnosis, it says we have basal cell carcinoma of the forehead, basal cell carcinoma of the right cheek, and then suspicious lesion left nose, suspicious lesion left forehead. But we do have some preoperative diagnoses. So this is where we're going to code from, okay? The basal cell carcinoma forehead with clear margins, basal cell carcinoma right cheek with clear margins. We're going to code for the compound nevus left nose with clear margins and the epidermal nevus left forehead with clear margins, okay? So just looking at that, I know that basal cell carcinoma, is that cancerous or non-cancerous? Yes, you can, Miss Patricia. Great job. Yes, perfect, Sarah. Yes, Elaine, Patricia, Brittany. So that basal cell carcinoma is cancer, okay? And the compound nevus, is that cancerous? The compound nevus and the epidermal nevus. So those nevus right there, are they cancerous or non-cancerous? Okay, perfect, Sarah. Great, Patricia, Katwana, Brenda, awesome. Amanda. Okay, so that's our non-cancerous, okay? So I know I'm gonna have category C and category D both here, okay, listed for my post-operative, okay? All right, just some things to pay attention to. Now, here's our keywords: basal cell carcinoma forehead, basal cell right cheek, compound nevus left nose, epidermal nevus left forehead, 47-year-old man, proven basal cell carcinoma forehead, biopsy proven basal cell carcinoma right cheek, basal cell carcinoma of right cheek, excised lesion of the forehead, right cheek, biopsies, left forehead, left nose, and what are we coding for? What ICD-10 codes are we reporting, okay? So I didn't need too many there. I can actually code this right from what it's telling me my pre-op diagnoses. So let's go ahead. Did I say pre-op? I meant to say post-op. Okay, our answer is B, okay? So let's find out why. Okay, so first of all, I'm gonna look at C and D, that code 644202. That's in both C and D, the first listed code there. Let's see what that's for. That's a cancerous code. That's for unspecified malignant neoplasm of skin of right ear and external auricular canal. Okay, so this is coding for cancer on the ear. If I look over my cancer, I don't see ear, I see forehead and I see right cheek. I don't see anything mentioned about an ear. So right away, I know I'm not coding for cancer of the ear, so I can go ahead and I can get rid of C and D. And then if I look at C44319, which is our first listed code in A and B, that's for basal cell carcinoma of skin of other and unspecified parts of face, okay? So that's going to match better than the code above, okay? Sometimes there's not a specific code for these various parts of the face, so you just generally code it from here, okay? So 644319 is going to describe better what's going on because this is parts, that forehead and cheek is a part of the face, right? We know it's not going to be ear, so we're going to get rid of C and D. Okay, so let's go on to these next listed codes. So in answer A, we have those 3 D codes. We have D04.39, and D04.39 is for carcinoma in situ of other parts of face, okay? And this right here, we're actually going to be coding this. I'll show you in just a second. That's going to be incorrect, okay? Because we have a more specific code for that. Okay, and if we look at D2, and it doesn't say that it's in situ. Basically, this carcinoma in situ. When it says in situ, that's hasn't became cancerous yet, and hasn't invaded the surrounding tissues. Okay, and then D22.39, that's for melanocytic nevi of other parts of the face. Okay, and if we look at what we have here, that's compound nevus, left nose, so that would be on the face, and epidermal nevus, left forehead. Those are both on the face, okay? So I do like that code, D22.39, and that's in both answer B and A, okay? And then we have that additional code in D48.5, and that's neoplasm of uncertain behavior of skin. So in order to code that, we also have to have in our documentation that it's not certain what type of if that, you know, what the behavior of that skin is, whether it's cancerous or not, okay? So again, that doesn't match what we have going on here. We want to just code for that nevus, right? So we can go ahead and get rid of answer A, okay? So the only code we need here, the C44.319, is going to cover the basal cell carcinoma for that forehead and cheek, and that D22.9, D22.39 is going to code the nevus, okay? So B is the correct answer. Does that make sense? How does everybody feel about that one? And I want to further explain this because I know it might be a little confusing. So let's just go and look at this. And typically I don't do this in a multiple choice setting, but I just want on this one kind of show you a little bit more in depth how we get those answers. Say we didn't have these multiple choice and we were looking these up. Okay, first of all, if we look in this neoplasm table, we're going to look for, we know this is basal cell is cancerous, so we're going to look up basal cell. Okay, it's going to be malignant primary there. Okay, and that gives us a code of C44.319. Okay. Okay, and if we look, because we're coding for the cheek and the forehead, if we look at the cheek, that also gives us C44.319, okay? And if we look at the nevus, D22.9, sorry, look up nevus, and then go down to left nose, or sorry, not left nose, just go down to forehead and then nose, okay? And that gives you the same code, okay? So you see that? So for your forehead and cheek, you're going to code C44.319, same code. And for the forehead and nose, you're going to code D22.39. Okay, it's the same code. All right. That's it. All right, so let me look in the chat now. Does everybody understand that? You got it? Let me know. Makes sense? Okay, perfect. So again, I just want to stress the importance of looking at those category letters. It really does help, and just knowing what your cancerous language is and your non-cancerous, okay? So awesome, awesome. Okay, so moving right along, I have another one for you. And Mr. James, can you read this one, please?
Sure. So I'll read the answers first. A is 11730, B is 11750, C is 11765, and D is 11720. Joe has a terrible problem with ingrown toenails. He goes to the podiatrist to have a nail permanently removed along with the nail matrix. What CPT code is reported? And we'll do 2.5 minutes starting now. And that is time.
All righty. Thank you so much, Mr. James. Okay. All right, so go ahead and get your answers in, everybody. Okay, so a lot of different answers coming in. Let's see, I think my chat is lagging. Give me 1 second. Actually, no, I was looking at the wrong. We have a lot of great answers on this one. It looks like probably almost 100%. Sorry about that. My chat was lagging. I just had to pull it all the way down. Okay, so looks like we're doing good on this one. Looks like you guys all got this one. So let's go ahead and first look at my answers. So if I notice, all of my answers here begin with 117. So we're just going to really have to read forensically here. Determine the differences between those codes. All right, so my keywords, I have ingrown toenails, podiatrist, nail permanently removed, and so was the nail matrix. Okay, so we had a nail that was permanently removed along with the nail matrix. Okay, and the answer is B, and this one really is just follow those keywords, which it looks like you all did. So if we look first at 11720, that is for debridement of nails by any method. This is going to be the wrong procedure. I don't see in my keywords where a debridement took place, so we can go ahead and get rid of D. 11730 is for avulsion of nail plate, partial or complete, simple, single. And basically, an avulsion is just, when it says avulsion here of the nail plate, that's just the removal of the nail plate, which is the hard part of the nail. Again, I don't see that that happened, okay? So I see it mentioning nail matrix. I don't see it mentioning nail plate. So we can go ahead and we can get rid of A. 11750, there's excision of nail and nail matrix. And the nail matrix is basically that tissue that's underneath the nail that your nail protects. So that's what's happening here. The nail is being removed as well as the nail matrix. So this says excision of nail and nail matrix, partial or complete. So it covers either partial or complete. Example for ingrown or deformed nail. This was an ingrown toenail here. Okay, for permanent removal. So I like that code. All right, so I'm going to place a star there, and I'm just going to look up my last one because I always like looking at all my answers here. 11765 is for a wedge excision of skin of the nail folds, okay? And that's also for ingrown toenail. However, a wedge excision of the skin of the nail fold did not take place here. We just had excision of the nail and the nail matrix, as it says right there in our keywords. So we can go ahead and get rid of answer C, and that makes B the correct answer. Okay, I think we're good on this one. It looks like you guys got it. You guys rocked it. Awesome job, everybody. Okay, so let's go ahead and move right along to our next one. And Miss Jeannie, can you read this one for us, please?
I sure can. Okay. Our answers are A, 11057, D, 23.5, D, 23.4, B, 11200, 11201 with modifier 51 times 5, D, 23.5, and D, 23.4, C, 11200, 11202 times 4, 11201 with modifier 52, and L 91.8, D 11200, 11201 times 5, and L 91.8. The patient is here to see us about some skin tags on her neck and both underarms. She has had these lesions for some time. They're irritated by her clothing, itch, and at sometimes have a burning sensation to them. We discussed treatment options along with risks. Informed consent was obtained and we proceeded. We removed 16 skin tags from the right axilla, 16 skin tags from the left axilla, 10 from the right side of the neck, and 17 from the left side of the neck. What CPT and ICD-10 codes are reported? And we'll do 2.5 minutes, and we'll start now.
Okay, I just want to step in real quick because I just realized that one answer in C has too many digits. Did you guys notice that? So that's supposed to be 11201, and I'll go ahead and fix it for you guys, okay? So it'll be fixed in just a minute.
All right, coders, seen some really good answers in the chat. If you haven't gotten your answer in, try to hurry up and do that. I gave y'all an extra minute. Seems like y'all could use a little more time, but it really seems to have paid off because I really like what I'm seeing in the chat. So go ahead and finish on up.
Okay, thank you so much, Miss Jeannie. That was well worth the time. Okay, I'm seeing great answers. You guys did an amazing job on this one. Wow, I think so far so good. I see that we are all pretty much in agreement on this one. Great job, everyone. Okay, so let's go ahead and go at this scenario. So if I look at my answers, B, C, and D share the same first code, then they also share the same second code with the exception of those multipliers and a modifier 51. Answer A, the first listed code, I always call it our oddball when it doesn't match up with the rest. And then we have some additional, some diagnosis codes here. Okay, so let's look at the keywords. We have skin tags, neck, and both underarms. There's 16 skin tags that are removed from the right axilla, 16 skin tags from the left axilla. We have 10 from the right side of the neck and 17 from the left side of the neck. Okay, so what I like to do with these is I like to list how many that I'm dealing with, okay? Because we are going to be coding for each one of these. And so our answer is going to be D. And I'm just going to chart it out, okay? So we know how many we have. So if we add them all up, the right axle is 16, left is 16, the right neck is 10, and the left is 17. That gives us a total of 59 tags that are being removed, okay? So if I look at my answers, first of all, I'm going to look at the oddball there, and that is for pairing or cutting a benign hyperkeratotic lesion. Okay, example, corn or callus. So what we're coding for here is skin tag, so that's going to be the wrong procedure. Okay, so we're going to go ahead right off the bat and get rid of the answer A. Okay, now let's look at 11200, which is in those 3 remaining answers, and that's the code we want. It's for removal of skin tags, and this code includes up to 15 lesions. Okay, so but we have a problem because we have 59, so we have to count all of those. We have to account for everything, okay? So 11200 will cover the first 15, and this 11201 that we see in the second listed covers each additional 10 lesions or part thereof, okay? So we'll just do a little bit of math. So, oh, sorry about that. So if I go back here, this 11201, we're not going to put a modifier 51 on that. That's going to be incorrect just on site. Can anybody tell me why? That's right, Eileen. Yes, that's right. That's a really good part of knowing your guidelines. You know that the 2 things we can never have with the add-on codes can never be first, and they can also never have a modifier 51. Okay, so if we ever see a modifier 51 that's appended to an add-on code, if for all of you who are new to group study or just still learning about coding, anytime you see this add-on code on a modifier 51 or a modifier 51 on an add-on code, it's automatically incorrect. Okay, we don't even have to give it a second look. So just like that, get rid of B. Okay, now let's do the math. So we know that that 11200 covers the 15 lesions. So we're just going to take the 59 total lesions we had minus the 15 that was covered in 11200, and we have 44 lesions left to cover. Okay, so 11201 times 4 would cover 40 lesions. Okay, each additional 10 lesions, if we code that 4 times, that covers 40. Okay, that's not enough, right? Because we need 59. So this 11201, it does go over, but it gives us what we need, okay? Wait, does it go over? Even if it does, okay, we need, okay, so 15 plus the 50 equals 55. Am I doing that right? No, we need to cover 44, I'm sorry. This would cover 11201. I'm not, as you guys know, if you've been with me, you know math is not my strong point. So this 11201 times 5 would cover 50, okay? So if we add that up, then we have exactly what we need, okay? So the 50 plus the 15 would equal 65. Actually, I don't know why it says 55 there. That's probably why it was throwing me off. So just remember that this is for part thereof, okay? So if we just had 1 over, you could still code 11201, okay? It doesn't have to be an exact 10 lesions. It says 10 lesions or part thereof, okay? Does that make sense? And sorry about my math there. And I think real quick, I want to fix that, okay? So give me 1 second. Let me just get that fixed. Okay. So it doesn't throw me off in the future. Okay, so let me go back through this. Okay. Okay, sorry about that, everyone. Okay, there we go. So that's where we need to be, okay? And so that would mean that C is incorrect. And if you notice that 52 modifier right there on 11201, just indicating a reduced service, we're not gonna put a modifier 52 on that, okay? We have to code for each one, and that's just not an appropriate way to code. So we're gonna go ahead and get rid of answer C. And if we look at L91.8, that's our diagnosis code for other hypertrophic disorders of the skin, okay? And sorry, D is going to be the correct answer, okay? Thank you, Miss Patricia. Anytime I have to do anything with math, you know, I'll probably mess it up, so sorry about that. Okay, so I'm going to move on. If we don't have any questions, if you guys got it, let me know you got it. Okay, perfect. All right, I'm seeing tons of got it. It's great. Okay, I love your participation. Please keep it up and keep those keywords coming. I'm seeing some great keywords in the chat. Okay, we have another one. And Miss Angela, can you read this one for us, please?
Of course. Okay, so we have A 11644 12052 modifier 51, C 44.319, B 11643 12013 modifier 51, C 44.319, C 11444 12052 modifier 51, D 49.2, D 11443 12013 modifier 51, and D 49.2. Pre-procedure diagnosis: basal cell carcinoma left chin. Procedure: wide local excision of 3.0 centimeter with 0.3 centimeter margin basal cell carcinoma of the left chin with a 4 centimeter closure. Procedure: the patient's left chin was examined. The site of intended excision was marked out. The site was then prepped. The patient was then prepped and draped in the usual fashion. A 15-blade scalpel was then used to make an incision in the previously marked site. It was carried down to the subcuticular fat. The lesion was then sharply dissected off underlying tissue, bed using a 15-blade scalpel. It was tagged for pathological orientation. The bifurcator was used for homeostasis. The wound edges were then undermined. The wound was then closed by tissue surrounding the lesion and closing in layers with 3-0 Vicryl for the deep layer, followed by 5-0 Proline for the skin. The skin closure was in a running subcuticular fashion. Steri strips were then applied. What are the procedure and diagnosis codes? Okay, so 3 minutes for this one, Miss Tracy?
Sounds great.
What do you
Thank you,
think?
Miss. Yes, that sounds perfect. Thank you.
No problem. Okay, so 3 minutes on the clock. Good luck, coders. Okay, coders, that's time. I'm seeing some pretty good answers coming in through the chat, so great job.
All right, thank you so much, Miss Angela. All right, everyone get those answers in here. All right, I see a little mixture going on. Looks like we have A's, B's, and C's. See some great keywords. Okay, coders, let me know. So looking at our answers here, I love these types of scenarios when we're dealing with these codes, 116 codes and 114 codes. So just looking at my answers and based off of what you already know in your keywords, let me know which 2 answers do you think that you can eliminate on site. Great job, Elaine. Craig, you got it. Sarah, Katoya, Haji, Amanda, Katwana, Patricia, Marquita. Great job, guys. Okay, so looks like majority are saying C and D, okay? And I'll show you a little trick if you don't remember already from part 3, but I know the ones who just finished part 3 remember that trick. It's kind of fresh in your minds, and I'll show you in just a second. Okay, so we have our key, I'm gonna go to my keywords. Basal cell carcinoma of left chin, excision, 3.0, 0.3 margin, basal cell carcinoma, left chin, 4 centimeter closure. Left chin, incision, wound, closed in layers. Okay, that's all I pretty much need is for my keywords. Okay, so the difference between these codes, it's good when we're coding for excisions, we want to know first, one of our major FTRs is it benign or malignant, okay? So in this case, these 2 codes, 116, if you look at the first 3 characters, that indicates a malignant excision, and the 114s are your benign, okay? So let me know in our scenario, are we coding for a malignant or a benign? Because that's going to make a huge impact on the way, on what we're going to be eliminating here. Okay, you all are saying malignant, okay? So I know that I'm going to be coding from 116 because those 116 codes are malignant codes, okay? And the 114s are benign. So let's go ahead and just look at these 11444 and 11443. Okay, that is for benign lesion. So you see the difference? That one says benign, and if you look over here at 11640 parent code, that's for malignant. Okay, so anything that's going to fall under this 114 is going to be eliminated, okay? And if you're not sure, like, hey, how do I know if this is benign or malignant? So this is a keyword as well, this basal cell carcinoma. If you look right here in your guidelines or description under your malignant lesion excisions, it tells you these excisions include simple closure. That's really important to remember. That's one of your FTRs. So anytime you have a simple closure, it's bundled. It doesn't get coded separately. And it tells you some examples of malignant lesions. Basal cell carcinoma is the first one there. So this is definitely a malignant lesion. Squamous cell carcinoma is malignant. Melanoma is malignant. Okay, this includes local anesthesia. Okay, and then you want to code these according to size and body area. Okay, all right, so now we've determined this is malignant, right? And if you look under benign, it gives you some examples of what a benign lesion is too. So just be aware that those are there. And based off of that, I can go ahead and get rid of answer C and D, just like you all are saying. Okay, make sense? Okay, perfect. Great. Okay, so let's move on and look at the difference between 11644 and 11643. And this is for, so we're coding for left chin here. This excision at the parent code, if we read that, that's for a malignant lesion, including margins, face, ears, eyelid, nose, lips, And then if we go down, it comes down to basically, so we already know we're in the right location, and it comes down to the excised diameter, okay? So if we go over here to our, what it's telling us, what the size of the lesion that was excised, remember when you're coding this, I want to ask first before I say anything, what do you think our excised diameter is of this lesion? Type it in the chat. Wow, you guys, impressive. Great job, Brittany. Great job, Katoya. All right, see some of you that are very close. So remember your excised diameter is going to be the lesion, the excised lesion plus the margin times 2. So if you have 3.0 and this margin it says 0.3, you have to have that on both sides, okay? Because you have margins on each side. So it's 0.3 times 2, okay? So it's 3.0 plus 0.3 times 2. That makes sense? Great job, Amanda. Okay, so 3.0 plus with the margins on each side, which is 0.3, would give you 3.6. Okay, so you just have to make sure you add another 0.3 on the other side. All right, so hopefully that makes sense. So that would be our excised diameter, which is going to fall right here at code 11644. Okay, so again, this requires a little bit of math, and it requires you to know how to code, how to calculate that size diameter. Okay, all right. So the next thing, the other thing that I see here, if you weren't quite sure about that, what's the other thing in B that is wrong? Does anybody know? Because that's also something to observe as well when you're coding for these excisions. You notice anything about that second code there in answer B? Yes, Brittany. On fire tonight. Yep, that's right. Great job, Patricia. So that, the difference between this second listed code, this is going to be for your closure. That top one, 12052 is intermediate repair, and 12013 is a simple repair. Okay, what did I say up here in our guidelines? It's telling us under malignant lesions. And if you had your FTRs listed at the bottom of the page that deal with these excisions, you would have that list in your FTR that these excisions include simple closure. So anytime a simple enclosure is done with an excision, it is bundled, meaning it doesn't get coded separately. Okay, so right there in answer B, we have a simple, we have a, I don't know what's going on, my clips. Okay, there we go. We have a simple closure there, and that's bundled. All right, so based off of that, we can get rid of answer B. And then when you see in our scenario that this was closed in layers, when you see it as plural, that would indicate an intermediate repair. Okay, so, and that would get coded separately. And if we look at 12052, there is our code for intermediate. Okay, and it said that the repair up here at the top was 4 centimeter closure. So we're right in there. 12052, 2.6 centimeter to 5.0 centimeter, because those also go according to body area and size. Okay, and then of course your diagnosis code there is basal cell carcinoma of skin or other body parts of face. Okay, so that's our final answer. I always love coding for these excisions, because if you know the guidelines, if you have those guidelines down pat, and especially you have those FTRs on your page pertaining to these codes, you're gonna rock this section, okay? So just know, benign, malignant, know the difference, know how to spot those codes, know that your simple closures are bundled, know some of those keywords, because if it doesn't say malignant, it might just have, it might say basal cell carcinoma, it may say squamous cell carcinoma, okay? So just know those keywords. And also take a peek at those keywords for your benign, because I know there's some listed there as well, okay? And those are your keywords as well for benign. Okay, so let's go ahead and move on. Everybody got this? Let me know in the chat. Got it, got it, got it. Okay. Well, at this time, I'm going to pass it on over to Mr. James, and he has a scenario for you. So whenever you're ready, Mr. James.
Sure. Okay, so I'll read out the answers. It's A, 17106. B is 17110. C is 17000 and 17003. And D is 17263. A 50-year-old female has telangiectasis of the face on both cheeks. She is very bothered by this and presents to have them destroyed by a laser. The physician lasers one cutaneous vascular lesion on one cheek, each lesion measuring 2 square centimeters. What CPT code or codes are reported? Let's do 2.5 minutes starting now. Okay, so that is 2.5 minutes. So let me just check the chat. And it looks like most of you have got this right. So let's go ahead and solve this scenario. So I'll highlight the keywords first. It's a 50-year-old female. And she's got telangiectasis of the face, both cheeks. And it is taken care of by the physician using laser. And it's a cutaneous vascular lesion, which is very important. It's a keyword. It's on each cheek, and it measures 2 square centimeters. So let's go one by one with the codes. Let's start with C. It is 17000 and 17003. And when we check that code, it is the destruction using laser surgery, cryosurgery, etc. But this is for pre-malignant lesions. And this case that does not say it's a pre-malignant lesion. Anybody of you know what this is? because we need to decide whether it's pre-malignant, malignant, or benign. So this is basically spider veins. Yes, that's right, Brenda. This is spider veins. So it's not pre-malignant, it's not malignant. So we can rule C out. And A says it's 17106, which is the destruction of cutaneous vascular proliferative lesions. Laser technique, less than 10 square centimeters. That is very close to this answer, so we kind of like that. But let's check the others too. 17110. It is the destruction using laser surgery, and it is taking care of benign lesions other than skin tags or cutaneous vascular lesion. See, this is very important, so you can mark it in your books. So that eliminates B. And let's take a look at the final D, 17263, which is treating malignant lesion. And this case is not malignant. It does not say in the scenario that it's a malignant lesion. I think I overclicked. Let's go back. So the answer is 17106, which is destruction of the cutaneous vascular lesion, and it's less than 10 square centimeters, each lesion measuring 2 square centimeters. So that's the scenario. Just let me know if you have any questions or you got it. All of you got it?
Wow, awesome, awesome. Looks like they're saying they got it, Mr. James.
Yep.
And I gotta say, give it up for Mr. James. What a wonderful presentation of that scenario. Thank you so much, Mr. James.
No problem.
Did an amazing job. Awesome, awesome. Okay. Well, I guess I can kick back for the rest of tonight. Mr. James is going to take over the class. No, I'm just kidding. But I'm going to hand it over to Miss Jeannie because Miss Jeannie does have a scenario for you all as well. So giving it to you, Miss Jeannie. Let me go ahead and, oops, give me 1 second. Sorry about this. Just have to make sure that I do this correctly. Okay, there we go. Whenever you're ready, Miss Jeannie.
All right. Thank you, Miss Tracy. Okay, let's do our answers first. So we've got A, 15002 and 15100 with modifier 51. B is 15937 and 15100 with modifier 51. C is 15937. D is 15937, 15100 with modifier 51, and 15002. This 37-year-old paraplegic has developed a sacral decubitus ulcer. He is brought to the OR today for debridement of the pressure ulcer with a split thickness skin graft to cover the defect. The patient was placed prone on the operative table after induction of adequate endotracheal anesthesia. The sacral area was prepped and draped sterilely, and the ulcer is inspected. The area is debrided extensively to healthy tissue. Involved bone, including part of the coccyx, was also removed. Once the site was clear of necrotic tissue, the site was prepared for a skin graft. A split thickness skin graft was harvested from the thigh with the dermatome. Total graft size was 25 square centimeters. The graft was sutured in place with 6-0 Vicryl. The harvest site was closed primarily with skin staples. Dressings were applied. Needle counts were correct ×2. The patient tolerated the procedure well. Code the procedure. All right, we will start with 2.5 minutes. And we'll begin now. All right, coders, go ahead and get your answers on in. I gave you a little extra time, and again, I'm telling you, it paid off. I'm really liking what I see in the chat. I'll just be telling you what you already know when I explain this one. But go ahead and get your answers in, and I'm going to go ahead and start going over this one. We'll start with our keywords. All right, so we have 37-year-old paraplegic, sacral decubitus ulcer. So that means the same thing as a pressure ulcer. Debridement, pressure ulcer, there we go. Split thickness skin graft, prone, debrided extensively, bone, part of coccyx removed, prepared skin graft, split thickness skin graft, 25 square centimeters. Whoop, oh, okay, that was a little fast. So as most of y'all were saying, the answer is B. And let's take a look here at Y. So let's pull up our first code here. So we've got 15002, and as you can see, it's under the surgical preparation section in our integumentary area. And it says surgical preparation or creation of recipient site by excision of open wounds, burn, eschar, or scar, including subcutaneous tissues, or incisional release of scar, contracture, and let's see here. So that one, as you can kind of tell from the words there, that's not what we're looking for. That's for open wounds, burn, eschar, or scar, and that's not what we've got here that we're working on. So let's, oh, this is very sensitive. So we can actually mark through A because that code is not going to make it correct. Then let's take a look at our next code here. And that is, so one under pressure ulcer, so 15936 is the parent code for our codes that's in BCND 15937. So that's for excision sacral pressure ulcer in preparation for muscle or myocutaneous flap or skin graft closure and with ostectomy. So that sounds pretty good. So yeah, it's a pressure ulcer, and with 15937 is with that ostectomy. And as you can see, in our scenario, it said that the area was debrided extensively, involved bone, including part of the coccyx was removed. So that is that part that we need to get an ostectomy. And as I mentioned, 15937, that is in all of the remaining codes. So figuring out that that one is good isn't going to quite give us the clue we need just yet. So, because that one's represented in all those answers. But if you look at D, it's got the code that we marked off first, 15002 in it. And see, yeah, that's so preparation is included in the excision of a pressure ulcer. Again, so that makes, again, that code not the one that we are looking for. So we can mark through D because it's got that same code in it as A, and that wasn't correct. So now we've narrowed it down to just B and C. So let's keep going. And we've got a parenthetical note here after our 15937 code that says for repair of defect in using muscle or myocutaneous flap, use codes 15734 and or 15738 in addition to 15936, 15937. And that's not what we had here. We had a split thickness skin graft. Right there, you can see that boxed off in our parenthetical note. And so if we have for repair of defect using split skin graft, use codes 15100. And here's what 15100 says. That's split thickness autograft, trunk, arms, legs, first 100 square centimeters or less. So there again in our scenario is split thickness skin graft, and it was 25 square centimeters. So that's definitely under 100. So that will work. And as you can see in C, it's missing that 15100 code for the split thickness skin graft. So we can mark through C, and that will make B the correct answer. So there we go. How did y'all feel about that one, coders? I think y'all probably don't have too much issue with it because you were really getting the answers right in the chat. And I will check here. Looks like, yeah, I'm seeing tons of B's here in the chat, so I think y'all did pretty good.
Yes, they did. Thank you so much, Miss Judy, for explaining that scenario to us. Great job. Great job. And coders, you guys are rocking it in the chat. Keep it up. Keep those keywords coming. I know Integ can be very wordy when we see the scenarios. Some of them are quite long, and some of those codes are quite extensive when we see all those codes listed. So you guys are doing a great job, and really that's why we focus on those keywords. So great job. Follow your keywords if no guideline overrules that. And we're going to move on to our next scenario, and I'm going to ask Miss Angela, can you read this one for us, please?
Yes. Okay, so we have our answers: A, 11200, B, 11312, C, 11442, and D, 11642. Patient presents with a recurrent seborrheic keratosis of the left cheek. The area was marked for a shave removal. The area was infiltrated with a local anesthetic, prepped and draped in a sterile fashion. The lesion measuring 1.8 centimeters was shaved using an 11 blade. Meticulous homeostasis was achieved using light pressure. The specimen was sent for permanent pathology. The patient tolerated the procedure well. What CPT code is reported? Okay, so for this one, I'll give you guys 2.5 minutes. Good luck, coders. Okay, coders, that's time. Go ahead and get some answers in here.
Thank you, Miss Angela. And again, you guys are rocking this one. Great job. So I don't think I have to spend too much time here. Looks like we pretty much have 100% on this one. I'd like to see that. Okay, so let's go ahead and see what's going on. So looking at my answers, I noticed those 114 and 116 codes in answer C and D. So I know those are for benign and malignant. Recognize those. And let's go ahead and see what our keywords are. We have a recurrent seborrheic keratosis, left cheek, shave removal, lesion is 1.8 centimeters, was shaved, and that's it. Okay, so we're shaving a recurrent seborrheic keratosis. And does anybody know what that is? Seborrheic, I don't know if I'm saying that right, but seborrheic keratosis. Just a fancy name. But anyways, it's one of the most common non-cancerous skin growths. And it usually occurs in older adults. And it usually appears black, brown, or lightly tan. And it can grow, you know, on various parts of the body. And to put it in simple terms, it's pretty much like a wart, okay? So it basically is just a lesion of the skin, okay? And it's non-cancerous. All right, so if we look over here at 114, we know that that is our excision of a benign lesion, okay? This is just simply a lesion of the skin, and it's going to be a shave removal of that lesion, okay? So this is excision. The 114 is going to be excision of benign lesion, so that's going to be the wrong procedure. So we can go ahead and we can get rid of that one, and we can also get rid of our malignant lesion because definitely this is not malignant, it's not cancerous, okay? So get rid of both of those, okay? And if we look at 11200, that's removal of skin tags. We already had a scenario like this, and this is not going to be our skin tags, okay? This is something different, and we're going to get rid of answer A, okay? 11312. This is our code for shaving. There's a key word. This was a shave removal of epidermal or dermal lesion. And if we go down, and that's for a single lesion, face, ears, eyelids, nose, lips, mucous membrane, and it basically goes according to size. So if we look at 11312, that's for a lesion diameter of 1.1 to 2.0. Our size here was 1.8, and our location on location was the left cheek, okay? So that's included here under our location. We have face. And what I like to do on these codes is just next to it, especially with our benign and our malignant, because those are according to body area too. I just like to place at that parent code what each location is. So for instance, this 11400 is for face, ears, eyelids, nose, lips, mucous membrane. And I also like to box the benign and also the malignant, okay? So those are just some coding tips for you. But going back to our code here, 11312, that matches the procedure that was done here, shaving of an epidermal or a dermal lesion, because that's what this seborrheic keratosis is. Like I said, it's basically just like a wart. And the lesion diameter is 1.8, and that falls right here in this range of 11312. So that's going to be our final answer. Okay. Okay, great job, Katoya. Awesome, awesome, Patricia. Okay, so let me know if you guys got this, and if so, I have another one for you. Are you up for it, Mr. James?
Yep.
Okay. I was wondering who was going to get this one. All right, everybody, brace yourself. We have a long one coming, and good luck to you, Mr. James.
Thank you. All right, everybody take a deep breath. So read out the answers. A is 19325 modifier LT, N 64.89. B is 19340 modifier LT, and Q 83.9. C is 19316 modifier LT and N 64.89. And D is 19342 modifier LT and Q 83.9. So the preoperative diagnosis is congenital left breast deformity, Post-operative diagnosis is congenital left breast deformity. Procedure performed is placement of left breast implant using Mentor catalog number, lot number, serial number, 425 cc's of smooth round moderate profile implant filled with 475 cc of normal saline for breast reconstruction. The indications for surgery: the patient is a 34-year-old female who approximately 15 to 16 years ago had a left breast implant placed for breast reconstruction for her congenital deformity of the left breast. This implant ruptured, and in late September, I performed a capsulectomy and exchanged her ruptured implant for a new implant. About a week after surgery, the patient developed an infection. Due to the infection, her implant had to be removed. The patient's infection has completely resolved, and she is now ready to have her implant replaced. In the preoperative holding area, I marked her for the ideal position of this implant and performed a breast exam, not showing a mass in either breast and no mass in the axillae, and we proceeded. We discussed with the patient, even though her original implant was placed in the subglandular position, I felt it would be beneficial to place the implant behind her pectoralis major muscle in submuscular position today. And the patient agreed, and we proceeded. The description of procedure. The patient was given 1 gram of IV vancomycin. The patient was taken to the operating room. General anesthesia was induced, and bilateral pneumatic compression stockings were worn throughout the procedure. A lower body bear hugger was used. Both arms were secured to padded arm boards using Kerlix rolls. The neck, chest, axillae, and upper abdomen were prepped and draped in sterile fashion. I began by incising the central portion of her previous scar. I dissected down to the pectoralis major muscle. A submuscular plane was developed through a lateral approach, and the inferior and medial origin of the muscle was partially divided using the Bovie cautery. Meticulous hemostasis was achieved using Bovie cautery. There were no signs of infection, nor were there any pockets of seroma fluid or hematoma. The wound was carefully inspected. Meticulous hemostasis was achieved. Gloves were changed. The implant was opened and air was evacuated. It was placed in the submuscular pocket, and the wound was temporarily closed using a skin stapler. The implant was filled to its maximum volume of 475 cc's of normal saline. The patient was sat up. I adjusted the volume and ultimately felt she needed a 475 cc implant for breast symmetry with her contralateral breast. Once I was satisfied with the position of the implant, the patient was placed supine. Gloves were changed again. The filled tube was removed, and I then secured the filled valves digitally, and the deepest layer of breast tissue was closed using 3/0 Vicryl in running suture, and the skin was closed in 3 layers using 4/0 monocryl, 5/0 monocryl, and 5/0 proline. The wound was dressed with Zeroform and gauze. The patient tolerated the procedure well. She was taken to recovery in good condition. What CPT and ICD-CM codes are reported? And let's do 3 minutes for this, starting now. And that is 3 minutes.
Okay, okay. Thank you so much, Mr. James. And thank you so much for reading that scenario for us. I know that was a long one. Like I said, these intake scenarios are very, very wordy, but really just focus on those keywords. And really, when you see the keywords I have, not very many compared to how many words we have here in the scenario. And if you notice, we only have one set of procedure codes here, and then we have some diagnosis codes. So this one's not as intimidating as it looks, just have to sort through what it's saying and what it's asking us to code for. So let's go ahead and see what everybody is saying here. Okay, so I have, looks like majority of you got this correct. Okay, so looking at my answers, I noticed that all these codes, the procedure codes, are begins with 193. Okay, so those are for, got to put our forensic glasses on because those codes are very close together. Modifier LT, so indicating left side, they all say LT. So then we have some diagnosis codes. So I like to always look at those category letters. I noticed Q. Do you guys remember what the Q is in our category? When we're doing our category recognition. You guys remember that one? Great job, Brittany. Awesome, awesome. Okay, so the Q, remember Q for question mark ear, which is congenital. So that would indicate congenital. Do you guys remember what the N is? I know this is one I don't think we will forget. Miss Rochelle always laughs when we say this one. Yeah, see, we always remember that one, the naughty part. So that's from the urinary section, okay? So let's go ahead and take a peek at what's going on here. So just kind of looking at that, we don't like to base our answers or our we don't like to look at the ICD-10 codes first, okay? We always want to make sure we look at the procedure codes, but it's always good to kind of look at those category letters as well to just see what's going on. And if we look here at the post-operative diagnosis, it's for congenital left breast deformity, congenital, okay? So that kind of gives me a clue about those diagnosis codes, right? Okay, but I'm still gonna look up the procedure codes first. My other keywords here, I have placement of left breast implant, 34-year-old female, 15 to 16 years ago. I have left breast implant, congenital deformity, left breast, infection resolved, implant replaced. We have general anesthesia, incising, previous scar, implant, implant again, implant again. Okay, so I like just those repeating words. I just like to highlight them as my keywords, okay? So let's go ahead and look at these answers here. First of all, I'm gonna look up 19316, okay, because that one's the one that comes first in these codes. So 19316 is mastopexy, okay? And mastopexy is basically a breast lift, okay? So what exactly is going on here? If I'm looking at my keywords, it says that this patient had a left breast implant that was placed after breast reconstruction for a congenital deformity of the left breast. So I like those LT modifiers. And the patient ended up getting an infection. So that implant had to be taken out. And there's going to be an implant that's going to be replaced when that infection was resolved. So now she's here to get that implant replaced, okay? So she's not here for a mastopexy. So that, and again, that is a breast lift. So we're going to go ahead and get rid of answer C. The next, okay, here we go. Sorry, I thought that was the same parent. So the parent for this one is mammoplasty, and mammoplasty is basically plastic surgery of the breast. It can be breast reduction, things like that. She did have breast reconstruction performed, but again, she's not here for that. She is here for an implant, however, not with the mammoplasty, okay? that reconstruction was already done, okay? So we are going to get rid of answer A, okay? So if you chose answer A because it says with prosthetic implant, yes, an implant is being replaced. However, she already had that breast reconstruction, so we're not going to code both of them, okay? And that's what 19325 is doing. So we can go ahead and get rid of A. And then finally, 19340 here, that's immediate insertion of breast prosthesis following mastopexy, mastectomy, or reconstruction, okay? So that would be immediate insertion of that breast prosthesis, which is going to be incorrect because she is coming back after that infection has resolved, okay? So that would be coded as 19342, answer D, which is delayed insertion of breast prosthesis following mastopexy, mastectomy, or in reconstruction, okay, as in this case, all right? And then I didn't even have to look up the Q83.9, but I like that it starts with a Q because this is for congenital left breast deformity, okay? All right, so tell me what you guys thought of that one. You guys got it? Got it, got it, got it. Okay, I'm seeing a lot of got it. You guys are doing great tonight. And this one wasn't so bad, right? Just have to kind of sort through what's going on and get to the correct answer. Got it. Awesome, Katwana. Okay, so let's go ahead and move along. I have another scenario for you. And Miss Jeannie, can you read this one for us, please? Are you there, Miss Jeannie? I can't hear you. Probably on mute.
Oh, I was, sorry.
I knew it. Thank you, Miss
Okay.
Jeannie.
Yeah. All right. So we've got A 15758, B 14301, C 14301, 11606 with modifier 51, D 15738, and 11606 with modifier 51. A 55-year-old male with a previous biopsy positive for malignant melanoma presents for definitive excision of the lesion. After induction of general anesthesia, the patient is placed supine on the OR table, the left knee prepped and draped in the usual sterile fashion. IV antibiotics are given. Patient had previous MRSA infection. The previous excisional biopsy site on the left knee measured approximately 4 centimeters and was widely ellipsed with a 1.5 centimeter margin. The excision was taken down to the underlying patellar fascia. Hemostasis was achieved via electrocautery. The resulting defect was 11 centimeters by 5 centimeters. Wide advancement flaps were created inferiorly and superiorly using electrocautery. This allowed skin edges to come together without tension. The wound was closed using interrupted 2-0 monocrol and 2 retention sutures were placed using number 1 proline. Skin was closed with a stapler. What CPT codes is or are reported? And we will start with 2.5 minutes and we will begin now. All right, coders, that is time. And I think this one will be a very good learning experience. I'm seeing that in a variety of answers. So I think the explanation will end up being really helpful for us.
Yes, I think so. This is going to be a good one. Okay. All righty. So see some more answers still coming in. So I'm just going to hold off for a minute. Okay. Okay, so let's go ahead and solve this. Okay, I see the chat's quieting down here. So looking at my answers, the thing that I noticed is that C and D have excision codes there, and that's all that I really observe. And then B and C have the same first listed code. Okay, so let's look at the keywords. We have 55-year-old, biopsy proven, malignant melanoma, excision lesion, left knee, excisional biopsy, left knee, approximately 4 centimeters, 1.5 centimeter margin, excision, patellar fascia, 11 centimeter by 5 centimeter, advancement flaps, okay? And I think that's all I have there. So you notice right here that I boxed advancement flaps. Can anybody tell me what an advancement flap is? What category does that fall under? Ooh, Katoya, on fire. Yes, Brittany, that's right. That is a really great keyword there. Okay, so advancement flap. Katwana, great, perfect. You guys did great on that one. Okay, so I'll show you in a second what that is. But first, let's go ahead and look at answer D. So I see a lot of you did choose D here, and this is this code 15758. This is for a free fascial flap with microvascular anastomosis. Okay, and an advancement flap did happen here. However, it wasn't a free fascial flap. Okay, so this is a specific type of flap. And this comes from our adjacent tissue transfers. Okay, so basically, mainly the tissue is still intact on one side, and you're just kind of rearranging that that flap to cover a defect. With this free fascial flap, I believe they're just taking this from anywhere on the body. It's not adjacent to that wound, and then they can apply it to anywhere in the body. However, this is not going to be the code we're using. If this is not going to be a free fascial flap, this advancement flap is actually another name for an adjacent tissue transfer, or it falls under the adjacent tissue transfer category. Okay, so so that one's going to be incorrect. If I look at, oh, you know what? I think I was explaining answer A to you guys. I'm sorry about that, 15758. So A is going to be wrong. And if I look here at 15738, which is an answer D, and I did see a lot of you guys did choose this one, okay? This one is for the muscle myocutaneous or fasciocutaneous flap, okay, of head and neck with named vascular pedicle. For the lower extremity, okay? And this is just a muscle, basically using the muscle, but this is very, going back to this advancement flap, this is what we're coding this as an adjacent tissue transfer, okay? So D and A would also be incorrect, okay? So we'll go ahead and get rid of both of those. Now, if I look at one, oh, actually, I want to show you guys. Before I thought something else was going to come up before I showed you this. Okay, let's look at this code first. 14301, that's in answer B and C. Okay, adjacent tissue transfer or rearrangement, any area. Okay, so there it goes. Here's my FTRs, okay? So our FTRs, we code these are for our ATTs, we code according to body area, okay? This one right here says any area, so we're good there because that covers any area. Excisions are bundled, code separately. Adjacent tissue transfers are a type of closure. Okay, our keywords here are going to be ATT. transfer, XYZ plasties. Those are ATTs. Stretch, pull skin over, rearrange, advancement flap, that's a keyword, yin-yang flap rotation, random island flaps, okay? And you can find some of those keywords on page 90 in your CPT manual. I would definitely highlight those, okay? Because those are going to be keywords you're looking for to indicate whether it's an ATT or not, okay? So in this case, we are coding this as an adjacent tissue transfer. Everybody got that so far? You following me? Okay, perfect. Okay, now based off of what we know and narrowing it down to B and C, can anybody tell me what our answer is? Just based off of what we have left. Yes, Brittany, perfect. I'm just curious. Elaine, great job. Twana, awesome. Brenda, great job. Yes, Kim. Patricia, awesome, awesome. Okay, so it looks like you guys got it now because we just went over the guidelines. So hopefully you know that what it says here is that excisions are bundled, okay? So did an excision take place here? Oh, sorry. I guess I had a couple more clicks. And remember, these do go according to the size, okay? So we have to just calculate the size there, which is going to be 55 centimeters, 11 centimeters times 5, okay? All right, so this 116, remember, those are our malignant excisions, okay? And it says that there is an excision of this lesion. However, what is our FTRs tells us that excisions are bundled. So anytime that you have an excision in the setting of an advancement flap placement, you will not code it separately. It is considered bundled into that code 14301 there. So based off of that, we can get rid of C, and B is the correct answer. Okay. Okay, so does that make sense? Everybody got it? Did you learn something, hopefully? Because I did see a lot of you chose D. So just want to make sure that everybody got this. We're on the same page. If you have any questions, please let me know. Okay. Okay, awesome, awesome. Okay, I have another one for you guys. Hope you are ready for it. So it's another big one. So I think it's you, Miss Angela.
I think it
Ready?
is.
Good luck. Thank you.
Okay, thank you. I think I'm gonna need it. Okay, here we go. We have A15002, 15004, 15100, 15220, 15221 times 3, 15240. B 15220, 15221, 15240, modifier 51, 15100, modifier 51, 15004, modifier 59 and 80, 15002, modifier 59 and 80, C 15240, 15220 times 3, modifier 59, 15221 times 3, modifier 59, 15004, modifier 59, 15002, modifier 59, 15040, modifier 59, D 15220, 15221 times 3, modifier 51, 15240, modifier 51, 15004, modifier 51, and 15002, modifier 51. An iron worker was working on the structure of a new skyscraper. While using a blowtorch to mold the rebar in position, he accidentally dropped the torch, engulfing his lower extremities. His coworker immediately extinguished the flames. The patient was taken via life flight to the hospital, and upon examination, the ED physician determined that the patient will require skin grafts on both of his legs and feet. The left leg required 40 square centimeters full thickness graft, and the right leg required a 40 square centimeter split thickness graft. Both feet required 10 square centimeter full thickness grafts each. The skin was harvested from the patient's trunk and buttocks to cover all of the wounds. The surgical sites of both legs and feet were prepared by the assistant surgeon. Which procedural codes best describe this encounter? I'll go ahead and give you guys 3 minutes on this one. Good luck, coders. And that's time, coders. I think some of you are still probably getting some answers in though, so give you some time.
Yeah, could you, Miss Angela, maybe add like another minute and a half? I know this one's like kind of a lot to sort through.
No problem. I'll go ahead
Thank
and set
you.
another minute. Okay, there you go. Okay, coders, that's time.
Okay, thank you, Miss Angela. Okay, I still see some of you are working on this. Great job, Ken. Awesome, awesome. You got it, Brittany. Lots of codes here. Great job, Sarah. Great job, Patricia. Okay. I still see a few answers coming in here. Actually, no, I see it slowing down. Okay, so let's go ahead and look at what's going on. Lots going on here. See a lot of, it looks like all these codes are from the Integ section, all beginning with 15, 150, 1501, 152. So not a whole lot. I do see a lot of modifier 51. I see modifier 80 there. I see some multipliers. So really, really a lot to sort through here. So the first thing that I'm going to do is, okay, I'm going to reveal the answer. Our answer is actually going to be B. Okay. All right, and so I want to look here because I see that there was some wound preparation. So where was the wound prep was performed on both the legs and the feet. Okay, and if we look down here at our FTRs, it's asking us, was wound prep performed? The answer is yes, wound prep was performed here on both legs and feet. I'm just kind of approaching this first from the standpoint of the FTRs to start somewhere. And then also we have to know if there's a graft, what type of graft. Is it allograft, autograft, xenograft? Is it, what thickness is it? Is it full, split, full thickness, split thickness? Is it tissue, epidermal or dermal? We're going to code these according to the body area. Debridement is bundled unless prolonged cleansing. We add the same grafts to the same body area, and harvest is bundled. Okay. So basically, I just wanted to kind of point out this wound prep here, and this wound prep was done on the legs and the feet. Okay. So just something to point out. All right, so now I'm going to go to my keywords. I have engulfing, lower extremities, skin grafts, both legs and feet. Leg is 40 square centimeter full thickness graft, really important to note that. Right leg is a 40 square centimeter split thickness graft. Both feet, it required a 10 square centimeter full thickness graft, okay, each. Harvested, trunk and buttocks, surgical sites, both legs and feet, prepared. Okay, so that is our wound prep. Okay, so let's go ahead and start. Oh, and we have this was prepared by the assistant surgeon. So that's also important to note. Okay, so there's our FTRs up there at the top. And again, pointing that out, we have to code according to the body area. Okay, so the first thing that I want to do, because I kind of like to categorize things, is I do see that we're dealing with a full thickness as well as split thickness here. So I want to categorize my full thickness first. So we have the left leg required a 4 square centimeter full thickness graft. So I'm going to put, for the left leg, we had 4 square centimeters there, okay? So if we look at 15220, that is a full thickness graft, includes direct closure of donor site, scalp, arms, and or legs. So this is the body area I want to be in. And remember, these go according to size. So we code according to body area and size. We have 40 square centimeters. So that 15220 covers the first 20, but we need to code the add-on code there for each additional 20 square centimeters, okay? So for this full thickness graft, we are going to code 15220 and 15221. So I'm going to document that there so that way I know. So that gives me a starting point, and if I look down at my answers there, I see that in some of the codes, okay? The next one that I want to code, and also note here that I'm going for my full thickness graft. Why? Because that's the more complex. So that would always get coded before the split thickness, okay, which we also see was there was a split thickness here as well. Okay, so the other thing I'm going to code for is the other full thickness graft, okay, and it says that both feet required 10 square centimeters full thickness each. okay? So left foot 10, right foot 10. So if we go down to 14240, so that's a total of 20. Okay, see how that's listed there. So if we go down to 14240, that's our full thickness graft, free, including direct closure of donor site, forehead, cheeks, chin, mouth, neck, axilla, genitalia, hands, and or feet. There we go. That's what we need right there. And that covers exactly 20 square centimeters. So we only need to code 15240 one time to cover that 20 square centimeters on the feet, okay? So remember the same body areas we add together, okay? So that gives us 15240. So now I know I need those three codes, okay, to start off with to cover for my full thickness graft. Okay, so looking over here at my answers, I see 15240 in answer C. Remember when we're coding, we always have to code the most complex. So why would I not code 15240 first? Does anybody know? Why that would not be listed first? Did I lose you guys? That's right, Sarah. Boom, that's what I'm looking for. So the legs have a larger area, okay? So when we're coding, we're gonna code this first because that's our 40 square centimeters, whereas this is 20. So you always code your most complex first, okay? And this is a bigger area, as Miss Sarah's telling us, so great job on that. So in answer C, that is less complex than our other full thickness graph. So based off of that, I can, and also this is coded incorrectly as well. It's asking us to code 15220 times 3. That doesn't make sense because we're coding 15220 only once, and each additional 20 centimeters get the add-on code, okay? So you wouldn't put a multiplier on 15220. So that's just wrong right there. And it's coding 15221 times 3. We don't put a multiplier on there because we only need to code that one additional time to get to that 40, okay? So you see why that's wrong by those multipliers. So, and by that first code. So we can go ahead and eliminate C, okay? And D, why is that wrong? Can you guys identify right away why that one is wrong? One of the main things, yes, that's right. That's right, Patricia. That's right, Kim, exactly what I'm looking for. So that modifier 51, we see on 15221 right there. Remember, we can't have a modifier 51 ever on an add-on code. So anytime we see that, it is automatically incorrect. Plus, we're not coding a multiplier there. But the most important thing to note here is that 51 modifier can never be appended to an add-on code. Okay, anytime you see that, it is automatically wrong. Okay, and that's something to just drill in your head because that's something I guarantee you'll be tested on the exam. Okay. Okay, all right, so moving along. So just like that, we narrowed it down to 2, and we know that we're coding 15220 and 15221 for the leg full thickness, and 15240 for the full thickness on the feet, okay? All right, so, and I do see those answers here in answer A, but pretty much we know we can eliminate that because we're not going to put a multiplier 3 there on that 15221. So let's continue. Okay, so just mark what we have here. Okay, so now we're going to go and we're going to point out what our split thickness, what we have for our split thickness, okay? So the right leg required a 40 square centimeter split thickness, okay? So we're going to document that, and that's going to be coded right here, 15100, which covers the trunk, arms, and legs, first 100 square centimeters. So this one covers up to the first 100. We have 40, so that code will cover that. Okay. So go ahead and document that, and we're down to our surgical prep now. Okay, so we're gonna go look at because there's surgical prep on I keep missing it. The legs and feet. Actually, those should have been part of my keywords. That's why I don't see them. So legs and feet were prepared by the assistant surgeon. Okay, so 15002. Oh, sorry, we're going to 15004 first, okay? So that's surgical preparation or creation of recipient site by excision of open wounds, burn, eschar, or I'm not sure what that says, scar, I think it says. And that tells you the body area, face, scalp, eyelids, mouth, neck, orbits, genitalia, hands, feet, and or multiple digits, first 100 square centimeters. Okay, so we're coding that surgical prep of the feet with 15004, okay? And note this, we have the 80 modifier there. That is for the assistant surgeon because the assistant surgeon is prepping that. So we would put modifier 80 for the for that, okay? And modifier 59 is there just because it tells us if you look in your FTRs, code according to body and size, and modifier 59 for different wounds. So we're going to put modifier 59 there. And also, if we look at 15002, that's our surgical prep for the legs, first 100 square centimeters. Okay. All right, so we can get, oops, sorry about that. So if we go back, A is wrong. I mean, that does say less complex there, but it's wrong because of that multiplier. It also doesn't have this modifier 80 on the surgical prep codes. So that one is wrong on a lot of different levels. So we can go ahead and get rid of A, and B covered everything that was done here. Our split thickness, our full thickness, our split thickness, and our surgical prep. Okay, so let me know what you guys thought. I know this one was long, and it was probably, I know you probably just didn't know where to begin on this one. So let me know if that explanation helped you to better understand this. I think if you know somewhere to start, you can just start. And I like to start just seeing what is going on. And I know here that I have full thickness and my split thickness. So I would just start there, like you saw me do. And I start calculating it out, looking up those codes. And then you have to ask yourself when you're doing these, was preparation done? If the answer is yes, then you go code those prep codes according to the body size, body location and size. And then here, assistant surgeon, that's a good clue because you code modifier 80 there for that, okay? And also another good clue is that modifier 59 in your guidelines, okay? That tells you to code it for different wounds. Okay, great. Well, I guess that's the end of class. I guess I got carried away. I didn't even realize that that was going to be our last scenario. So hopefully you guys are okay with that ending on that note. I know that was a lot. I know someone goes, oh man, it goes by so quickly, doesn't it? All right, and if anyone has any questions, I'll stick around and answer them for you. I want to thank my wonderful team. Miss Jeannie, you did an amazing job tonight. Thank you for solving that scenario for us. It's always great to have a different perspective, so I really appreciate you, Miss Jeannie.
Oh, you bet. Thanks for having me. I really enjoy doing the scenarios, and it helps me learn as well, kind of seeing how, to solve them and then how to explain it in a way that makes sense. So it really makes you kind of think about it extra or twice as hard. So it's really good practice for me, and I like doing them with you all.
Well, thank you, Miss Jeannie, and I agree. I mean, I can't even tell you, we learn by doing, and I'll be the first one to say that. And it's, it really does, really does help to do these, so it helps us to help you guys. So we are so happy to be here with you guys. Mr. James, give it up for Mr. James. Tonight was his first night solving a scenario, and he did an amazing job. Thank you so much, Mr. James. And I know he had some long scenarios to read. So Mr. James, thank you so much for sticking in there with it. And thank you for that wonderful scenario. You did a wonderful job.
Thank you, Ms. Tracy. Thank you for the opportunity, and I look forward to solving more scenarios with all of you. And it was great hanging out with all of you fellow coders. So have a good night.
Thank you so much, Mr. James. And Miss Angela, thank you for being a trooper. I know I wasn't planning out what scenario, what each one of you guys were going to get. I was just calling you out by name, and it happened to be that you were getting a lot of the scenarios that were very long and had a lot of codes. So thank you for sticking in there and getting your material at the last minute and coming and rocking it. Thank you so much, Miss Angela.
No problem, Miss Tracy. Thank you for having me tonight. Thank you, coders. You guys were amazing. You did really good despite the long scenarios. You guys got a lot of those answers correct, so that's awesome. You guys are great.
Exactly. And last but not least, yes, shout out to you guys. You guys did an amazing job tonight. Integ, I gotta say, I haven't been in Integ for a while, so when I was prepping for this class, I almost forgot how long. I'm usually in E&M, and we do have we have different types of scenarios in there, as some of you know that are in my E&M class. We have those auditing scenarios, which everybody loves, right? But Integ is just a little bit different. We have majority of scenarios in Integumentary are pretty long and pretty extensive on the codes, as you can see in this one in front of you. So thank you for sticking with us. I hope you learned something tonight. Everybody's dismissed if you have no questions, and please fill out the survey on your way out. Let us know what you thought of tonight, what you learned. If you had any aha moments, definitely love to hear that. And I want to say have a great night. Don't forget to sign up on Wednesday with Miss Rochelle to study some musculoskeletal and respiratory. I know she has a great class. She always has a great class planned for everybody. And yeah, we'll see you then. Good night, everyone. Good night, everybody. I think I see a question here. Yes. So, Chesley, if you're still here, I hope I'm saying your name right. You do have to sign up for every group study that you wish to attend. So when you want to sign up, when you want to come to the group study on Wednesday, make sure to go into your Student Resource Center module and just go and sign in there. Go to your track 1, go to the drop-down menu, and you can actually sign up for all the classes from now until the end of the year for each one of your tracks. So you don't have to, keep going in there week after week, but you do have to sign up for each one that you wish to attend. That way you can receive the link. It's not a recurring link, okay? Okay, you're welcome. Ah, thank you, Miss Patricia. It's always a treat to have you in class. All right, I don't see any other questions. So on that note, good night, coders, and we'll see you soon.
Good night.
Good night, Miss Jeannie.
Good night.
Good night, Mr. James.